and then discussing possible scenarios going forward. So we have 3 speakers this afternoon. Our main speaker is Kerrigan McCarthy. Kerrigan is the head of the Division of Public Health Surveillance and Response at the National Institute of Communicable Diseases in Joburg. And then Marianne Davies and Andrew Bull, who you know well from these webinars, who are from the Western Cape Department of Health and the School of Public Health and Family Medicine at UCT. So we're going to go forward to the presentations from Kerrigan, Marianne and Andrew in sequence. Andrew will start out providing a short update on the Western Cape epidemic, as we've become used to in our webinar series. And that'll be followed by Kerrigan's talk. Kerrigan will talk about the evolution nationally and the experiences in other provinces, where we are now with the epidemic and thinking about potential scenarios going forward. And then Marianne will follow that with a few slides on some of the thinking at a provincial and national level about surveillance to detect a potential second wave of infections. And then following that, we will have a panel discussion. And our 2 panelists this afternoon are Jabulani Mqayana. Jabulani is an epidemiologist in the Division of Epidemiology and Biostatistics at UCT, and Hassan Mohammed, who is a public health medicine specialist at the Western Cape Department of Health, as well as Stellenbosch University. So I will hand over to Andrew, who will first give us the update from the Western Cape, and then if Andrew could then hand over to Kerrigan and Kerrigan to Marianne, and that'll be followed by the panel discussion. So over to you, Andrew.
Thanks very much, Graham, and greetings to everyone. I just want to check first that you can see my screen.
All good.
Yeah, good, great. So I'm going to be very brief today because there's much more interesting speakers coming up, and I'm just going to follow the familiar format, just a week's extra data. So as is evident, the testing numbers have declined over time, but actually the last 3 weeks they've been fairly consistent, maybe a little bit lower last week, but the positivity has fallen even further, starting to drop to as low as 10% positivity in the most recent days. And as a result, that case numbers have fallen even further. So you can see a consistent decline in case numbers. And to put that into perspective, in a week at the moment, we are enumerating between 2,000 and 3,000 cases. And there was a time when we were enumerating that number of cases in a day. So it really does reflect the dramatic decline from when we were at the busiest period. And that is reflected as well in health workers, perhaps not declining as much, but still a decline in hospitalization, continued slow decline in hospitalization and in mortality as well. So if just putting it all on one graph, it's a very consistent picture of gradual decline in burden. The cases in grey, the positivity dropping in yellow, the deaths as recorded nationally and as recorded on date of death on our own systems, with some allowance for underreporting. Confirmed COVID admissions and COVID admissions, including public sector PUIs, and then the oxygen, bulk oxygen utilization, which we haven't updated for the last week. This is paralleled very closely by the mortality measured by the MRC by a week, and these are the natural deaths, and we've been showing these graphs every week for a couple of weeks. For the first time now, the natural deaths are within the confidence bands of what would be expected for the week up until the 18th of August for the province, and actually almost touching the expected line for the city. Now, remembering that we are still enumerating 200 deaths a week in patients with laboratory confirmed COVID diagnoses. And so this goes very closely with what Marianne and I have both referred to in the last 2 weeks, which is that our deaths from natural causes outside of COVID have declined this year compared to last year. So whereas there's been a lot of discourse about whether the excess deaths described by the MRC are truly COVID related, we now have the situation where we have more COVID enumerated deaths per week in the province than are described as excess deaths by this analysis. The other point I'll just make on the slide is you'll see that there's close to 5,000 excess deaths described, which we think is quite an accurate reflection for the province for the period. And if you back calculate that into the provincial population, that gives quite a high mortality per million population compared to global estimates. Marianne made that point last week. And if you assume infection fatality ratios that are similar to what are described globally, it would suggest that our population seroprevalence should be 20% or higher. And we're not in a position this week to share any seroprevalence data, but the early indications are that we are in those ranges. So we're following a pattern much more similar to India than to Europe. And I'm mentioning that now as context for what Kerrigan's going to talk to later, even though we'll only present the detail next week, because I think it is material to our thinking around resurgence, second wave, etc. So with that, I'm going to hand over to Graham to introduce Kerrigan. I think, oh, he's introduced Kerrigan, so over to Kerrigan. Thank you.
Everyone hear me?
Loudly and clearly.
Great, super. So good afternoon, colleagues. Thank you very much for the honor of being able to share with yourselves this afternoon. I've had the privilege of working with Eastern Cape Public Health and Metro Health and Provincial Health folk for the last few weeks. And it's been truly wonderful. And I couldn't help but put this picture on my opening slide that here's the Western Cape and then there's the rest of South Africa because I've enjoyed working with you. But one of the unfortunate honors that the Western Cape has had is that you have been the first to manage the COVID outbreak in many respects. In as much as you were the first to peak in big ways, the first to provide field hospitals and experience the massive impact on clinical services. You're also now the first to experience the post. You're also the first to experience the post-COVID wave, or at least the post-COVID period. And it's this that is causing a lot of the world's great level of everyone's perplexed, wondering how to move forward into the space. The wonderful thing is that you have so much to share with the rest of South Africa. And that being said, I also thought it would be lovely to share with you correspondingly what the South African, the broader South African experience has been in terms of how the epidemiology has unfolded, how the national government has tried to organize itself, the National Department of Health, and the broader epidemiological pictures, so that in some ways, as our heads are buried in the clinical business of managing COVID, we have a chance now to breathe and look up and see where things are going. So it would be wrong for me not to acknowledge everyone from the start, because the info that I'm sharing with you, certainly very little of it has its origin with me. My NICD colleagues have organized themselves into an epidemiological team, and they produce these superb daily reports on both the cases, the lab testing, and the hospital admissions, and these are available on our website. I've drawn extensively from the incident management team presentations that are shared twice weekly on Tuesdays and Thursdays. And I've also acknowledged many of the insights and learnings from the Eastern Cape colleagues and yourselves in the province. So in this afternoon, I hope to share with you several perspectives. The first is the story of the first 8 weeks, what happened at the NICD, and how the Department of Health was trying to organize themselves. Share with you how the current structures have evolved and what those are. Give you some reflections on the April-May period in the Eastern Cape province and parallel it with what was happening your side. Then to share with you the current slides that were presented at the IMT on the epidemiology track yesterday. Yes, and then look at what is the incident management team up to at the moment, just to give you a snapshot of what they are discussing, and then end off with where we're headed. And then I'm going to hand over to Marianne, who will give some reflections on global seroprevalence surveys and what these might mean for us going forward. So the first 8 weeks was a complete and utter nightmare. There were several aspects of leadership and coordination, case detection, contact tracing, data management, and clinical guidelines and communications that were all handled by a very small team within the NICD. The National Department of Health had started an incident management team, but it was primarily led from the NICD. And there was confusion in the roles and responsibilities between what the NICD did and what the National Department of Health did. The case detection mechanisms that we had thought through in the peacetime during the 4 weeks that we had before our first case were hopelessly overwhelmed. We had a 24-hour hotline that at one stage was receiving over 20 to 30,000 calls in a 24-hour period. We had a system for collecting data on patients using a PUI form, as you may remember, and our original plan that was that these all go to the NICD, and we just couldn't keep up with the data entry, couldn't employ people fast enough. The contact line lists got stuck at the NICD, and of course they were needed by the provinces. We were also trying to phone and follow up contacts, and then there was some overlap with the provinces. Every sector of society was asking for clinical guidance, and there was no capacity at the NICD, and every single radio station wanted an interview, and it was a crazy time. Of course, we know now, looking back, that even though we detected the first case on the 4th of March, that there had probably been multiple introductions of SARS-CoV in the last week of February and the first 2 weeks of March that remained undetected. And of course, we were anticipating this because and we now know, looking back with the vast numbers of asymptomatic cases, it was inevitable that we would miss the first few cases. When we looked at our data and put it all together, we realized that we had multiple importations, at least amongst those who had a professed travel history, predominantly from Europe, but also from the United States, the Middle East. And biologically, from a molecular perspective, we did have introductions from China, but we never identified these. Our government acted swiftly, as did a few other countries in the world, and initiated a lockdown very rapidly. And you can see the graph at the top right that the impact of this initial lockdown had on curtailing the importation of cases. So we were hectically trying to organize ourselves. We had an incident management team that had a number of tracks, and this was predominantly led by the NICD with the support from the National Department of Health. It was housed at the NICD Emergency Operations Center. The National Health Council was operating business as normal and wasn't really involved in COVID at that stage. As the days and weeks passed, we became increasingly accountable to NatJOC, which is the National Joint Operations Committee. And at the start of the lockdown, our president created a National Command Council into which NatJOC reported. A few weeks later, the minister wisely appointed a ministerial advisory committee, and this ministerial advisory committee spoke directly to the minister, but also provided advice and actionable recommendations for the incident management team. And probably around about the same time, the Department of Health opened a project management office supported by Ernst & Young to support the more administrative, financial, logistical components of the outbreak. So the structure that we have now looks something like this. The Ministerial Advisory Committee has 52 academic specialists who provide technical advice in the form of advisories, and if approved, the incident management team of the National Department of Health becomes the effecting and implementing body. The Project Management Office is chaired by the DG of the National Department of Health and includes all areas of the NDOH, including administrative and, very importantly, financial and managerial staff. It also oversees contracts, and it was supported by Ernst & Young in the initial days. The NHC, the National Health Council, and the NHC Tech was a pre-existing body, but became deeply involved in COVID as time passed, because it became, as it should have been, the vehicle for communication of NDOH policy to the provinces and the mechanism by which provinces are held accountable for service delivery. And so when there were new policy changes, and the most recent one, of course, is the reduction of the incubation, quarantine and isolation period to 10 days, these kind of documents landed up going through the National Health Council. So they start off at the Ministerial Advisory Committee, where technical and academic and theoretical opinion is generated. They may go to the incident management team, who then refers them to the project management office, and then may refer them to the National Health Council. Ultimately, everything goes through the National Joint Operations Committee, and this is a body that's chaired by the South African Police Service. It is in fact a security organ and deals with all aspects of security related conditions in the country. And then, of course, finally to our minister and to the National Command Council. So that's how we organize ourselves today. You can imagine that there's an incredible amount of bureaucracy, and sometimes things can be frustratingly slow. So, for example, the clinicians guidelines, the version 5 that was released, I think this morning, has been ready for about 4 to 5 weeks, and has taken its way to make its way through the bureaucracy. So we tried to get around that in various ways, for example, by publishing draft guidelines and the like on the website. Big decisions can be made and pushed through with a lot of lobbying and pressure, but it's, as you'll see, it's certainly not because the Ministerial Advisory Committee is not working hard. So very early on in the outbreak, around about the 19th of March, I was lucky enough to be sent to the Eastern Cape, and so I was able to compare at various levels what was happening in the Eastern Cape with what was happening in the Western Cape. So the Eastern Cape was relatively late to get its first case. The initial cases were reported. The first case was a teacher from Grahamstown who had returned from working in the UK. But by the 18th of April, the Eastern Cape was well set to be the 4th highest province after KwaZulu-Natal, Gauteng, and yourselves, the Western Cape. Like yourselves, where there had been initial amplification events. Classically, Hassan Mohammed shared a story of a wedding where the bride had a cold and later tested positive for COVID, but there were similar amplification events in the Eastern Cape. There was a funeral at Port St. John's, and then tragically, a prison in East London was affected. One of the persons who warders had attended the funeral in Port St. John's and come home and brought it into the prison. So these early days, when we look back and cleaned the data, Stefano Tempia from the NICD was able to calculate the estimated effective reproductive number during the first 8 weeks. We had to impute the symptom onset date, and the epidemic curve you see on the left shows imported cases versus local cases. The graph on the right shows the moving estimated daily reproductive rate, and you can see a marked decline. The two horizontal lines represent the first curtailment of public mobility, followed by, on the 27th of April, the hard lockdown. And you can see a marked decline in the reproductive rate. We were able to calculate the effective reproductive rate across different provinces. And the most reliable calculation to use is when the imported cases were considered as transmitters only. And you can see the Western Cape province had a relatively low reproductive rate compared with the others. But the most important thing to observe here is that the reproductive rate never went below 1. And as a consequence, the disease became transmitted in various parts of the country. In the Eastern Cape, there were 2 epicenters, the Nelson Mandela Metro Bay and Buffalo City, Port Elizabeth and East London respectively. And each of these, if you looked and zoomed into the epi curve, you could see local or discrete areas where there had been transmitting events that had accounted for early entrenchment and subsequent spread of the virus. In Nelson Mandela Metro Bay, the prison outbreak, a number of funerals, retail outbreaks at shopping centres also contributed to the curve. And in Buffalo City, 2 specific events, the prison outbreak, and secondly a local GP who publicly released his name, and so I can share it with you, but he had over 140 contacts, of whom 8 to 10 that we know of developed COVID through contact with him. And these events served to entrench the outbreak. Of course, you were aware of what happened in your own areas with the hotspots in Tygerberg and Khayelitsha. The Western Cape initially had superbly robust contact tracing, but of course the cluster outbreaks in essential services seeded the vulnerable areas and then created hotspots. And so if we look at the 2 provinces, in the Eastern Cape, one of the challenges in the over populated areas was delayed readiness of quarantine and isolation facilities, and particularly difficult social distancing in small towns, especially on grant payment days. Contact tracing was difficult, particularly in the outlying rural areas where there were communication challenges with regard to the results. There were problems in the supply chain management of PPE, and this created immeasurable tensions between the unions. And very soon, like yourselves, there was a laboratory testing backlog. In terms of the Western Cape, you're all familiar with what happened here, and many similar issues happened. So some of the in-depth work that when we worked with the contact tracing teams, we, particularly in Buffalo City, we were able to measure the median time from a positive test to interview of contact, and this was around 5 days, but had a range of 0 to 13 days. And really this made containment of the virus without meaning. The photograph on the right was a video taken from Siki on the grant payment days. It was exacerbated by regulations that said you can only allow certain numbers of people in shops. So then the streets became crowded correspondingly with people while they were waiting to go into the shops and buy. So you led the way really in curtailing testing on the 1st of June, limiting testing to high-risk persons, following extensive lobbying and unsuccessful attempts to get the NHLS to up the game. And this had a major impact, and you can see it on the graph showing the weekly incidence rate per 100,000 persons. The limited supply of test reagents, followed by the change in test policy, caused an almost flattening of the curve, and of course to the lay public that was perceived as a good thing. So where are we now? The 2 graphs and the next few slides are taken from this week's presentation to the incident management team. You can see that very soon after the Western Cape peaked, Gauteng, followed by KwaZulu-Natal, Free State had a sharp rise in the weekly incidence rate, with the cumulative incidence risk per 100,000 persons still remaining the honor of yourselves. People have expressed concern, of course, that the decrease in the weekly incidence risk is a function of testing capacity and testing rates, and it's difficult when one looks at this graph over here, which shows the number of tests per week in both public and private sector, with the 7-day moving average. The number of tests has definitely come down, but what is difficult to disentangle is that by and large a substantial proportion of tests is through passive surveillance. So that's individuals seeking care because of symptoms. And so as the prevalence of symptoms comes down, the health-seeking behavior changes, and persons won't necessarily go for testing. So what is helpful is to look at the testing rates per person per time, and then very importantly, the proportion positivity. If we look at, and I'll show that in the next slide. So the testing rate per person is in the order of between 600 per 100,000, with a low rate in Limpopo province of just under 100,000. And this has been paralleled by a progressive decline in public sector turnaround time, which is a relief for everyone, probably representing both an increase in testing capacity as the NHLS has brought on additional testing machines and strengthened the reagent supply chain, but also a function of decreased burden of testing. The proportion positivity is an important thing to watch as a marker of the likelihood of illness and the progression of the outbreak. And at a national level, top left, you can see a progressive decline in the number of in the proportion positivity from a high of around 30% to a current national average of around about 20. We can break that out by province per epidemiological week, with the most recent week being in dark black. And we can see that the Western Cape has the lowest proportion positivity. At the moment, the highest is in the Free State. Gauteng is also relatively low. The weekly reports produced by the NICD show the proportion positivity by sub-district, ranked in order with the 95% confidence intervals. And we can see that there are certain areas within the Western Cape, Eastern Cape, Gauteng, that have very low proportion positivity, but those there are those that are still within the range of 30%. The NICD every now and then, for the incident management team at the National Department of Health, does an in-depth analysis on one or other component of epidemiological focus. A few weeks ago, we looked at pediatric population under the age of 18 years and under, 18 and under. To date, 33% of the over 600,000 cases are in children under the age of 18. And when we look at the incidence risk, it is incredibly low. It is in around the same order of magnitude as of meningococcal meningitis. So it is very uncommon in children under the age of 10. We see a progressive increase in incidence. And of course, this is symptomatic infection. So this is infection that has resulted in health-seeking behavior. The incidence risk per 100,000 population is also correspondingly much lower than that of adults. And again, the Western Cape led the way for a while, but has been usurped by the Eastern Cape and Gauteng. If we look at admissions of children, you can see that the admission rate is also relatively low for children aged 10 to 14, and higher for children aged 15 years and over. But comparatively, there have been more admissions for children. The number of admissions by age group is shown in the graph below. The NICD supported the rollout of the DAT-COVID hospital surveillance. At the moment has all private facilities across the country at just under half of the public hospital facilities. The Minister of Health decreed about a month ago that all provinces need to come on board and register, and so the team is busy back capturing hospital admissions due to COVID. So at the moment the system has around just under 60,000 admissions recorded, and you can see the distribution by public and private facility, and you can also look at male versus female and the outcome of hospitalized patients and deaths by age. So the big question is, where does all this epidemiology put us in the world? If we look at other countries that have equivalent socioeconomic conditions and Gini coefficients, and in some cases population size, and which also implemented an early lockdown, we're pretty much doing a similar trajectory. So those countries are Colombia, or at least the ones that I'm aware of and have chosen for this comparative purpose, is Colombia, Argentina, and Mexico. So all countries like us had first cases either in late February or early March, and then implemented a hard lockdown around about the same time as we did. And the comparative graphs from our World in Data show the new daily confirmed cases and the number of deaths below. And you can see we seem to have turned the corner on the other side of the curve. Colombia is leveling out. Mexico maybe have turned the corner, and Argentina still seems to be on the upward trend. But the burning question, of course, is where are we going today? Now, before I get there, I just want to give you a snapshot of what the National Incident Management Team is doing. What I'm going to do is give you snapshots of presentations from the areas, what we call the functional streams, and give you a sense of what happens in these discussions and kind of the decisions and work that the incident management team does. So the NICD is responsible for the epidemiology and surveillance track. We have a number of key activities. Obviously, we do the ongoing data cleaning and reporting. We receive through direct electronic transfer the results from all the laboratories that are doing testing in the country, and we collate and clean these and share them in the data lake with the CSIR, the National Department of Health. We're also busy summarizing key data findings for the peer-reviewed literature. So we're looking at the first X cases, hospital admissions, pediatric admissions. We also do specific case series analyses, and then the Center for Respiratory Disease and Meningitis, led by Prof. Cheryl Cohen, has embarked on a number of investigator-led research studies, the most interesting of which is the first study. So this is taking place in two sites, in a rural site, Agincourt, and in Matlosana in Klerksdorp area. And this involves a cohort of persons who are being intensively studied twice weekly, have nasopharyngeal swabs. They're wearing proximity proximity markers, and the aim really is to estimate the community burden of SARS-CoV and assess the transmission dynamics. And this will provide us with some important information around the incidence of infection and illness, particularly the significance of asymptomatic infection, whether or not it's transmissible and under what circumstances. Also the impact of age stratum, HIV status, and underlying illness, both in progress, outcome, and transmissibility. And of course, we'll also be able to use the cohort to look at identification of repeat infections. There is a serological component as well that will be able to correlate the seroconversion rates, particularly for asymptomatic infection. The IMT supports, and here's reports from a stream that provides technical support for case management and contact tracing. There are two components to this, in addition to the other element elements of the data lake. The first is COVID Connect. So this is a system that has a dual purpose of providing persons to undergo testing with their results, and that's for both public and private sector, but it also then collects data through patients who self-monitor and submit their contacts, and it allows visualization of these on an interactive platform. It also, in the bottom right, has a tabular view that allows contact tracing teams to monitor and follow up and identify patients who need in-person contact. So one of the challenges with the system is poor uptake in the field. So we started off relatively well with a 25 to 27% receipt of results, and things have declined in the recent weeks, but there is an extensive marketing campaign that is happening, and hopefully that will support buy-in and make the system a complementary system to support contact tracing in the district. The case management team has a number of hats. They support infection prevention and control, guidelines to support occupational health, to support infections in schools. As I shared today, the guidelines for clinical management have been released, and they're over 5 weeks old, so you already all know the contents. The team has input from personal protective equipment, stock monitoring, and you'll be pleased to know that the Auditor General's report is discussed weekly to understand the extent of appropriate use of funds or misappropriation of funds. The stock management is served by a stock visibility solution, which pharmacists will be familiar with. They have been using the system for a long time, and a PPE reporting tool with interactive dashboards. And so at a national level, the levels of PPE can be assessed, stockouts can be anticipated. And so the system has advanced greatly over the last few weeks. There's obviously been increasing concern around cause of death based on the MRC's reports of the excess mortality and the relative uncertainty at the moment because of the delays in the death registration system as to what the cause of death has been. And so the Department of Environmental Health at National is enacting guidelines and recommendations and training to support the collection of post-mortem nasopharyngeal swabs from all persons dying outside of hospital. So this is in progress. You'll all have heard of the WHO visit, and people have asked, well, what are they coming to do here? They're coming to do and are busy with at the moment an intra-action review. There are guidelines published by the World Health Organization for how this should be conducted. The team of 50 plus people has been allocated to different provinces, and their role there, as shown in the bottom, is to conduct a rapid assessment to understand the national response through a desktop review and then key informant interviews, to participate actively in all the work processes, both at provincial and national level, and then to provide reports regarding our processes and our strengths and weaknesses, hopefully for improvement in our responses. The other thing the IMT does is receive the provincial situation reports, and these are discussed, and in-depth visits and meetings are held with various needy provinces to support data analysis. So the NICD is integral to this. We have 9 provincial epidemiologists who are providing in-depth epidemiological support for managing COVID. And lastly, there is a communications division which conducts and facilitates at a national level communication activities to support behavioral change interventions. So where are we headed? The models, thankfully, have been wrong. And of course, the modelers have got into a lot of trouble with the lay press and the lay public about this. Models, we know, are only as good as our assumptions. And of course, our assumptions and our behaviors and our policies and procedures are continually changing. And so it is important that revisions are continually made. If the models were true, we should have had over 1 million cases at the moment, and we have at present 600,000. So we're grateful we're wrong. But that does call into the question why the models were wrong. And Harry Moultrie and the Modelling Consortium have suggested 4 separate reasons and managed to alter models, and each of the hypotheses could account for the change in models. The first is that there may be some residual immunity to coronaviruses, and that the entire population is not as susceptible to SARS-CoV as we thought. The second reason may have been that the behavioral response may have altered as the outbreak rolled out through and swept through communities that caused death, and so people changed their behavior when they realized that this was not a conspiracy or a pandemic. There also may have been better adherence to non-pharmaceutical interventions for the same reason, and behavioral heterogeneity. And so the next iteration of the models is coming out. Of course, we expect the next iteration of the models to take into account this phenomenon, and that is called the second wave. So what is the second wave? We're all familiar with the Spanish flu pandemic that occurred in 1918. This was followed by a second peak of infections, and again in 2009, when the resurgence of H1N1 came about, there was a second wave that in the United States was in fact larger than the first. Various people have conjectured around, are we going to see a third or a fourth wave, or a resurgence, or peaks and valleys and falls and peaks, or are we going to see seasonal COVID? How are things going to pan out going forward? And this is particularly important question as our clinical burden decreases, and we all become more complacent about COVID, and we think, oh, maybe it wasn't so bad and it's going to be all right. So many European countries that passed the initial COVID peak are experiencing a second peak, and you can see this beautifully here. The number of countries: Spain, France, Germany, United Kingdom, and then also South Korea. You can see a lovely U-shaped dent in the curve, and this is accompanied by an initial decline in the proportion positivity, followed by an increase in the proportion positivity, as seen in the case of Spain in the upper graph. So what are the potential drivers of a second wave or ongoing resurgence? We can learn from the lessons from influenza, possibly a change in viral transmissibility, behavioral changes in persons, population heterogeneity at both the behavioral, geographic, or genetic level, virus mutation, or waning immunity. And of course, some of these are more or less likely for SARS-CoV as they compared with influenza. Certainly, it doesn't seem yet that virus mutation is a factor to consider. Waning immunity, we're uncertain about this. Time will tell us how pervasive and what the duration of our immune responses are and how effective they are. And we don't think that the virus is changing transmissibility, although there are some indications that the environmental ambient temperatures and humidity may impact on this. So what characterizes the COVID outbreaks where second wave is occurring? The Spaniards have put forward that relaxation of adherence to non-pharmaceutical interventions combined with low levels of population immunity may have led to the increase in cases in Spain. A seroprevalence study there showed that predominantly under 15 to 10% of persons were seropositive. An interesting retrospective assessment of the impact of lockdowns and social distancing on the 1918 flu pandemic showed that the earlier the lockdowns were implemented, the less likely there was to be a second wave, and of course there were fewer deaths. Don't know if that's directly applicable to us in our time. The other question is there anything we can learn from countries that are not experiencing a second wave? And a lot of these are the very countries I've mentioned before. We've had an early lockdown. Possible reasons are that the initial peak is not yet reached, also that the number of cases is not reflective of the actual epidemiology because of low testing rates or case definitions or incomplete surveillance, or alternatively, and of course we would love it if this were true, that the control measures or lack thereof have determined or led to a particular epidemiological picture. And the question there is, could increasing levels of immunity account for these epidemiological patterns, or what is the seroprevalence in these countries? To end off, what is definitely certain, whether we get a second wave or resurgence or peaks, is that we cannot do without non-pharmaceutical interventions, laboratory testing, contact tracing with effective quarantine and isolation, and of course careful thought regarding public health policies for the next phase. Tom Frieden had a quote that really consoled me as we look back on our sort of almost haphazard, at times poorly coordinated response to COVID, is that a country that responds well to COVID is not one that has consistent policies, but one that has policies which are responsive to the data. And that really leads nicely into lessons that we've learned, and then into Marianne's sharing with us around serology. So outbreaks at public health events have shown us, and this is beyond question, that the people in our healthcare system are responsive. We have capacity to change and adapt, and we can do what is required if our motivation is sufficient. This communicable disease outbreak has shown us that preventive health services need major emphasis and investment, that health promotion and wellness messaging is critical, and that community engagement and ownership are essential to achieve cooperation with non-pharmaceutical interventions. So that's really all I want to say. I'm going to hand over to Marianne, who will let me know when to change the slides. Thanks.
Thanks very much, Kerrigan, and it's been fascinating to get an insight into the inner workings of the NICD. Kerrigan has taught about outbreaks on the master's module in infectious disease epidemiology for a few years now at UCT, and one of the things that came back to me time and time again in those last couple of weeks of March and early April was that Kerrigan said the most important part of managing an outbreak is coordination. And so it's I think reassuring to hear about some level of chaos everywhere. And thank you very much for that. And I think also just to say that one of the things I think all of us have come to realize is the unintended positive consequences of COVID. And one of those has been the opportunity to work much more closely with NICD. So we're very grateful for that. So I think we can go to the next slide. What I'm going to outline is that as we are thinking about this possibility of a second wave, one of the most important things is to have a surveillance strategy that is going to be able to pick that up so that we can respond to it very quickly. And I think when we think about surveillance, if it's not something we do all day, every day, we tend to think about it as kind of one big block of activities, and are we going to do serology, and are we going to do PCR? And so I've tried to just outline some of our provisional thinking. None of this is cast in stone yet. Some of the things we've started doing and some of what is planned. And the way I've tried to think about it is that the first piece is really saying, well, how bad was it? What was the severity of the first wave? And that's what I've got on the left-hand side. On the basis of that, what is our future risk of infection? And if we had information about what proportion of the population has been infected and we have information on the deaths, then we can start to think about what our infection fatality rate actually was. And so to do that, we need to determine the proportion of the population that has been infected in typical epi-way by place and person. And the way to do that is with seroprevalence. And we have planned a fairly extensive survey by the HSRC. The NICD is also planning an in-depth survey in Mitchell's Plain, which is their respiratory pathogen surveillance area. And then much more opportunistically, and what we're going to hear about next week, is the testing of residual specimens from patients that are coming for clinical care for other reasons, and to try to get ones that are as close to representative of people who are not coming because they're desperately sick. We will be looking at residual antenatal and HIV viral load specimens. And this approach is actually, I was interested to see, is not something unique to us, but has been widely used, for example, in the US as well. So that'll give us a sense of where are we and start to help us to think about our vulnerability in terms of a second wave, and whether we may perhaps by default in some areas have reached levels of infection and immunity that could give us some degree of protection. Then in terms of finding the second wave, obviously we want to be following very closely the rate of increase in infection, where that is happening, and importantly, the molecular characteristics of viruses that are causing infection as we go forward and whether those are changing. And there are a range of approaches for that. And I'm going to talk about everything except the first line in the green block first. So the first part of that is repeated seroprevalence, and the HSRC very fortunately has added in a follow-up cohort to their study. The planning for the antenatal and viral load residual testing of specimens is going to be ongoing. So it's hoped that, for example, on the first week of every month, a subset of those samples will be tested, which will allow us to look at changes over time. The NICD will continue with testing of a range of viruses in patients with respiratory illnesses from its sentinel surveillance sites. And that has been particularly important in showing, for example, the reduction in influenza infections. And then we will look at ways to incorporate molecular testing in a subset of viral specimens so that we can track the molecular epi of the outbreak. And then what's emerging as a very exciting novel way of tracking the outbreak is looking at testing of wastewater, which can detect SARS-CoV-2 RNA in the wastewater, and in various ways can then help to identify areas where there might be people who have active viral infection. And then, of course, the most important part for containing a new outbreak will be the identification of individual new cases for isolation. And it's the tracking of those cases, which is what we've been doing all along, that feeds into the first line of identifying the rate and areas of where new cases are occurring. And so that serves the dual purpose of both being able to identify a second wave as well as enabling us to implement containment measures around individual cases. And obviously for that to be a sensitive measure, we need to start thinking about expanding testing criteria. And I've actually just come from a provincial meeting where there is some discussion of how we do a graduated expansion of testing criteria, but balance not risking those long turnaround times and also not wasting tests. So testing where it's needed, and in certain high-risk settings or in closed settings, either where patients are at high risk of severe illness or where there's high risk of spread, to consider testing of asymptomatic contacts, which is recommended by WHO and CDC in certain settings. And importantly, we often think of surveillance as being sort of a method and a population as separate, but I think what I want to highlight is that all of these approaches could be applied to a whole population or to a particular setting. So we could, for example, do a sero-survey in healthcare workers to assess the severity within healthcare workers and future risks of infection, or in a particular setting such as a long-term care facility. And the wastewater testing in particular has got very nice applications where one can look at areas within a city where there are infections, or where one could, for example, do regular wastewater testing of a particular facility, such as a prison, to see if one needs to be concerned about infections. If we can move to the next slide. So this is hopefully giving you a taste of something that we might see next week. This is looking at serology from New York. And on the left-hand side, undergone serological testing for 100,000, quite a bit of variability. And then on the right-hand side, the percent positive, with quite dramatic variability within the city and much higher seroprevalence. For those of you who know your New York geography, in the Bronx, which is on the top right-hand side, and then just below that in Queens, which reflected where the cases came from. But hopefully for the serology that we are doing, at least for different sub-districts or for the catchment areas of particular facilities, we'd be able to get a sense of diversity of exposure within the metro. And then lastly, we can go to that last slide to talk about just to show some of the potential of the wastewater surveillance. So the left-hand side shows the correlation between the number of active cases in the dotted line and the SARS-CoV-2 viral load in wastewater. And on the right-hand side, the reason that I chose this particular image is just to show that proportion positivity that Kerrigan highlighted and how sensitive that is to what's going on in the epidemic, but that is matched very closely by new cases and also by viral RNA in wastewater. And so we're hoping that using a combination of these methods, we will be well placed to be ready for the second wave. And I was told a couple of weeks ago that we were first with the initial outbreak and that we better do everything we can to make sure we're also not first with the second wave. And with that, I'll end and we can go to questions. Thanks very much.
Thanks very much to Kerrigan, Marianne, and Andrew for a highly informative and comprehensive overview of the national picture, and Kerrigan for sharing those insights into really the nerve center of national monitoring of COVID-19 and the thinking and actions at a national level. So we're going to move on to our panel, and as I said at the beginning, we've got two panel members, and just going to ask Jabulani Yana, who's an epidemiologist at UCT, to make one or two comments, or if there are any questions that you want to ask.
Yeah, thanks, Graham. Yeah, thank Kerrigan, Marianne, and Andrew for the very interesting presentation. So I have one question, Kerrigan, in terms of course, now the buzzword is the second wave, and you have presented different scenarios, but do we have a concrete definition of what we would define as a second wave for South Africa, and how would that look like, or as opposed to a surge or resurgent, or those are we thinking those as the same thing? And to Marianne and Andrew, the dashboard for Western Cape is very informative in terms of breakdown of the cases, and I think it's even down to a sub-place. Is there any reason why we are not reporting deaths or mortality in that same granularity in the provincial dashboard? Thank you.
Thanks, Jabulani. I'll go first. The definition of a second wave, that's pretty important because otherwise we don't know what we're looking for. There's at the moment a ministerial advisory committee that is dealing with this exact question and has been tasked with defining it. I think the definition is pretty arbitrary in the sense that we know the broad parameters. We're looking for a change in positivity rate, and we're looking for an increase potentially in absolute numbers. But there may be nuances to that. For example, we may have localized I want to say outbreaks in vulnerable communities. We may also have, of course, increased incidence rates or relative risks. So the exact definition is still being worked out, and I think whatever definition we use, the most important thing is that we continue to detect and count and do comparative measurements of our cases. Over to you, Marianne or Andrew.
So I can comment on the dashboard briefly. So initially we didn't report deaths particularly, we only reported overall numbers of deaths and not down to district or sub-district level, because the number of deaths was very small and we were concerned around possible loss of confidentiality or identification or stigmatization if the numbers were very small for an individual sub-district or district. But we recently, the provincial dashboard hit 1 million views, and we decided that it was time to update it. And so I think about a week ago, it was relaunched, and there's now a little tab that says additional analyses. And there it is possible to view deaths by sub-district as well, as far as I am aware. Andrew, I don't know if you want to comment more.
Just to confirm, and I was going to screen share it, but it's just the screen sharing is disabled. So
Okay.
yeah, it is there.
We believe you, Andrew. So thanks, Jabu, for those questions. We're going to move on to Hassan Mohammed. Hassan is a public health medicine specialist at the provincial government in the Western Cape and Stellenbosch University. Hassan's really been central in the provincial response in the Western Cape. So Hassan, any comments or questions that you have?
Thanks, Graham, and thanks, Kerrigan, Mary Ann, and Andrew for those inputs. I'm going to give a few reflections, and I think whoever of the panelists or whoever of the presenters want to respond can do so. Just firstly on seroprevalence, I mean, I think if the provisional data that Andrew mentioned suggests that we are sitting at around about 20%, it suggests that there are 80% of people who are still susceptible. And this suggests again that we are at risk of further outbreaks, or a second wave, if you like, or mini outbreaks. And we kind of need to understand better who these 80% are. Again, assuming that seroprevalence gives us some idea as to who's immune and who's not immune. I think the second issue I want to talk about is the balance between our work on COVID-19 and the other activities of our health system. We're going through a period of normalization, and we know that other services for TB, for HIV, for maternal and child health have all suffered, and we need to bring them back on board. Otherwise, we'll have a new set of crises to add to the COVID-19 crisis. And it's about how do we strike the balance? Where does COVID-19 fit in that list of priorities that we face as a health system? We know from the health department's point of view that given the weakness of our economy, we're going to be facing further budget cuts in terms of public services, including health services. So prioritization is going to be important. And I think that's going to be a challenge, and we need to think about how best to do that. Thirdly, I think, we have these tools such as lockdown, quarantine, isolation, contact tracing, etc. And these are tools being used internationally. I think one of the challenges all along has been how do we adapt those for local use? How do we apply them locally? And we've had to learn as we go along. And we've improved the way we carry out these activities. But I think, this whole question of having tools that are available for us as public health practitioners, but it's about the complexity actually of how one implements them in a particular setting. I think the last point I want to make is just about uncertainty, and that, that's been a big challenge all along. It's led to lots of debates and arguments because we simply don't know enough, and we don't have enough evidence for a lot of the interventions that we are applying. And that just makes it difficult going forward. But at the same time, we can't avoid making choices. We have to make choices about what actions we embark on, who do we test, do we do contact tracing, and to what extent we apply isolation and quarantine measures, and to what extent do we balance our services. These are difficult decisions, and it's even more difficult having to make them in the absence of clear evidence. Thanks.
Regan, do you want to respond?
Yeah, maybe I'll have a first go. So I liked your last point, Hassan, because you said uncertainty is the name of the game, and I think none of your questions have answers. And indeed, this has been the most challenging aspect of managing this outbreak. The small fortune globally is that we relatively behind other countries, particularly Europe, Southeast Asia. But that may well cease to be the case as the outbreak takes different forms in different epidemiological contexts. I think you raise an absolutely essential point regarding the balance of health services and the need not to create more trouble for our people further down the line through an under-emphasis on routine and relatively easily treatable conditions. The adaptation of contact tracing to local conditions is a very interesting question. We've seen relatively good uptake of, say, for example, proximity Bluetooth apps and in Europe with apparent success where small communities all use the same app. The question is, how useful will these things be in our particular context? How do we engage with the community to make contact tracing acceptable? And how do we encourage quarantine and isolation? We've had varying success across the country with these, and really there are no answers other than the broad principles of communicable disease containment and the need most definitely to protect the remaining 80% who remain susceptible. So that's no answer, I'm afraid. Maybe Marianne and Andrew have answers.
Mark, you unmute. Marianne?
So I have no answers except that we need to get used to living with uncertainty. And I thought there was a very nice piece in an article that I read a couple of weeks ago. I think Sean Busserman was one of the authors, which said that despite the fact that there's no textbook, we have to make decisions. And I think that's sort of been the story of the last few months, is having to make decisions in the absence of perfect knowledge. And that the better data that we have, the easier it is to feel comfortable with those decisions, even in the absence of perfect knowledge, because we know that, for example, even if the modeling is imperfect, we can track quite quickly whether we are following that trajectory or not. And that was certainly very helpful in our experience to be able to know quite quickly, actually, it's not happening the way we thought it might. Andrew, I'll hand over to you.
Yeah, I have nothing to add. I think Hassan does all very salient and thoughtful comments, and yeah, I think everything's been said.
Yeah, thanks, Hassan. So before we go to the any questions or comments from the chat function, I just wanted to pose one question to Kerrigan. You've obviously compared the South African epidemic to many of the other countries that have sort of gone before us in terms of a surge. And one thing that characterized what happened in Asia, in Europe, and then the New York experience was there was this massive upslope of cases and then a lockdown and then a decrease. Whereas, you know, something that South Africa's experienced is, you know, our increase happened after we started relaxing lockdown. And now after 4 to 5 months going down, despite no new measures having been implemented. Is there any country in the world that actually has that pattern where we've seen a decrease despite no new measures being introduced on a community level for prevention?
I mean, I can't speak with too much authority, and there may well be folk who know better more than me where the other countries are in these trajectories. But certainly Mexico looks like it's leveling out and possibly turning the curve. There was a time when Colombia did. In fact, they even published a paper saying that early lockdown was successful, or asking, was early lockdown successful in limiting the size of the outbreak? But they've subsequently had not really a resurgence, but the drop wasn't as big as had initially seemed. So it's incredibly difficult to be able to draw any inferences from other countries with the absence of data. For example, the question around, what is the seroprevalence in certain aspects of Colombia? Is it comparable to us? The Indian study showing very high seroprevalence in informal settlements was perhaps hopeful, in the sense that one wonders what the herd immunity threshold is, and the corresponding reduction in vulnerabilities with an increase in seroprevalence. I think we're all tending to hope that perhaps we've served our country well, sort of by default, with having had an early lockdown and having had limited success with that, which has really led to sort of propagated outbreak, and perhaps the turn in the curve is a function of increasing population immunity and fewer susceptible encountering infectious cases. But really only time is going to tell, and more data. So as Marianne and Hassan have alluded to, the more data we know, the better we can model, the better we can measure, the better we can have insight into those factors that are driving the change.
Yeah.
Over.
So, Kerrigan, we're going to open it up to questions from the chat room, and I'm going to turn to Mark Sondrup. If there are any questions, Mark, that you want to pick out.
Right, just before we go in the last few minutes, I think Jabulani Mayana had one more comment to make.
Yes, yeah, thanks.
Jabu,
well, that's my last question. Yeah, I wanted to pose to presenter about it builds to what you were saying, Graham. If on the we want to collect some of the data around behavior, and Kerrigan, we're talking about it could be there was a good compliance with the NPIs, but we don't really have that data. As in the future plans, are we going to collect some data around behavior and compliance or of using these preventive measures? Thanks.
Yeah, thanks, Jabulani. There is, I understand, a ministerial advisory committee dealing exclusively with behavioural issues, and I'm not familiar with any outputs of these. Certainly, there is a subgroup on the ministerial advisory committee that's looking at the potential for a second wave, and there have been some excellent reviews done of the success of non-pharmaceutical interventions in containing COVID. I fully agree with you that at the moment that's really the only tool in our armory to deal with COVID, and a further and deeper understanding of factors that promote adherence to this is worthwhile. Over.
Thanks, Graham. Yeah, Graham, I'm going to just touch on a few questions. There really have been many comments and questions. I'll try to repost many of them. Maybe just start with a quick one first. And it came from Mark Mendelson saying that, I think to yourself, Kerrigan, you mentioned that cross-immunity with other coronaviruses may be a plausible reason for the lesser numbers that we expected in the modeling. But it could have created herd immunity in high transmission SARS-CoV-2 areas. But what about high density areas as a driver of reduced numbers? Your thoughts on that?
I'm not really clear on the question. High density areas in the sense that there's pervasive infection and so high levels of immunity. Is that what you're meaning?
I think that's the number of the question.
Yeah. I mean, that's highly plausible. I mean, what's uncertain is the duration of immunity, but what is clear is that broadly neutralizing antibodies are formed and certainly persist in the short term. And so areas where there has been extensive penetration of the virus into the community and therefore correspondingly high seroprevalence does stand to reason that this will contribute to turning the curve, so to speak, decrease the effective or transmission rate in that particular community. That's my feeling. I mean, I don't know. In fact, there's no evidence at the moment that there's cross-reaction serologically with other coronaviruses. I just put it out there as an idea.
Okay.
Over.
Thank you. I'm going to dovetail two questions because there's been quite a few around this particular issue, so I'm going to combine two because I think it'll cover it broadly. And it really is around international travel. The one came from Susan Cleary asking, obviously we need to start opening the economy, we need to take advantage of international tourism, and you know, this needs to happen in the next short while. What are the chances, do you think, that we could indicate when we intend reopening international flights? And when could this announcement, you know, perhaps be expected? Given that we may have protection against the second wave, hopefully, would this be a selling point? I know it's a complex question, but then Mark Mendelson indicated in the same vein, bearing in mind the introduction of new strains into South Africa from travellers, and the risk of super spreading events in a waning local epidemic, what is your advice on reopening international travel into the country?
Yeah, I think there is this ongoing tension between balancing vulnerability of the population with economic needs. And what is absolutely certain, and I think Hassan alluded to this, is that there are still extensive sections of our population that remain vulnerable. And there is an absolute need to continue with non-pharmaceutical interventions. Whether that precludes the opening of international travel is a matter for its own consideration, based on the economic needs of the country, which are absolutely critical. So the question is, can one reopen travel safely? And what are the consequences of introducing new strains? At the moment, there does not seem to be significant evidence of genetic mutation that can lead to so-called escape variants. The virus doesn't it doesn't have an error-prone RNA polymerase. There has been a recent report in Hong Kong of a strain that is markedly different and able to cause a different clinical, or at least a more severe clinical presentation. But really, you know, there remain many questions. I have no idea at a national level where the discussions are at regarding opening up of international travel, but I would assume that it is imminent and that we will take the lead from countries that have been at similar stages of the outbreak as we are. Over.
Thank you. One of the last few questions then to anybody, Marianne, Andrew, or Kerrigan. Really pertinent one. It's from Nora Ferrell saying that we've shielded our more vulnerable groups, older people, diabetics, etc., in the Western Cape. Are we able to pause this now, bearing in mind that we may have to, you know, reinstate some degree of lockdown again going forward? Any thoughts on that, Marianne?
So I'd actually suggest unmuting Hassan as someone to answer this question, but my suggestion would be no. We still have a large number of cases. We still have large proportions of the population who have not been infected, and I don't think we're out of the woods yet, but I'd be interested for Hassan to comment.
Hassan?
Yes, thanks. No, I agree with Mary Ann. I think certainly it would be premature for us to, you know, start reducing these restrictions or pausing the protection of, you know, vulnerable groups. Certainly we need to continue them given the proportion of the population that's still susceptible, the potential for risk of further outbreaks or further mini outbreaks, if you like. So we would certainly promote that. You know, I guess, you know, one needs to consider for how long one needs to keep this going, but I think for the next few months at least. And I mean, I think what we're talking about internally in the Western Cape is looking at this in terms of 6-month bites, if you like. So for the next 6 months, let's pursue a course of action, review it after 6 months, see if we still need to continue it, watch what's happening globally, etc. So, you know, as I said earlier on, there's an environment of uncertainty. We need to keep monitoring, learning, researching, and as we get new knowledge, we can perhaps better decide. But I think to err on the side of caution and to maintain restrictions as much as we are able to should be continued. Thanks.
Thank you. Graham, I'm going to throw the last question to you. You can decide who you put it to. And I think it's just because it's been topical the last week. And it's the issue around reinfection. Have we had documented so-called reinfection? And is there a diagnostic algorithm for reinfection? That's the last case, Graham.
Kerrigan, can I throw it at you as originally a lab person?
Yeah, no, I think I'll throw it back to you as a clinician. I mean, all I can say is that the epi curves don't suggest that reinfection is a significant driver of the epidemiological presentation, but time will tell. Beyond that, we know that there are neutralizing antibodies that are performed. We don't know how long they last. We don't still have to characterize patients who have recurrent infection. Is it something about their specific immune responses, their susceptibilities? So there are many questions. I'm sure, Graham, you'll have your thoughts on this. Over.
I think, you know, given that there's been over 20 million infections worldwide, and this week we have 3 cases of reinfection, it's taken a long time to document those, which just illustrates that it's very rare and should not be foremost on people's minds when patients come back with symptoms. You know, I think it can happen, but it's very rare. Just doing a repeated swab for a PCR and finding that positive does not confirm reinfection. It's just persistent PCR positivity in the majority of people. And to my mind, given that it's so rare, given that the original test cannot be reliably used to confirm a repeat episode, you know, I think it should only be considered when you get a very typical representation with a COVID pneumonia. And those patients could be worked up with input from a specialist because it would take, you know, to really confirm a recurrent episode, a repeated infection. A second infection would take a viral culture or a sequencing of the 2 samples to show that you know, that it's 2 different strains. And I don't think somebody who's representing with a simple upper respiratory tract infection with no complications warrants that level of workup. I think it's really when that it's when somebody represents with a COVID pneumonia type picture, and then it needs you know, specialist expert advice as to how to work that patient up and manage them. But I think the key message is it's rare, and we're not going to have a public health guideline for something that's only had 3 cases worldwide. But we'll have to watch and learn as we go, because it might become more common, and then that answer would change. So Mark, I'll just make some concluding remarks then.
Yeah, thank you.
So just to say thank you to Kerrigan, all the speakers, all the panel members. We've had a really informative, excellent webinar today that really kind of gives us a sense of where we are in the epidemics in South Africa. To also say that today marks our 20th webinar in this series, a very successful series, and just to acknowledge Wendy Spearman and Mark Sundrup, who came to me about 5 months ago with the idea of opening up the ECHO project webinar series to focus on COVID, and thank them for all of the practical work that they've done over the last 5 months to make this series successful. And then the people that have worked behind the scenes, Karen Fenton, Cheryl Valentine, Sahana Ranglal, and Claire Jeffrey, to really put in the organizational work to make these webinars happen, to make people aware of them, and to put the recordings online that can be accessed through the Department of Medicine website. So we'll be having our next webinar next week, same time. and the focus then will be on the liver manifestations of COVID, and Wendy will be our speaker next week. So we'll look forward to having you back on the webinar next week. Thanks very much.